So the next speaker is someone who's familiar to many of you who are at the foundation because of his work with PHCPI. Asaf Bitan directs Ariadne's PHCPI work. In addition to that, he's a primary care physician in the Division of General Internal Medicine at Brigham and Women's Hospital, and also a member of the Department of Healthcare Policy at Harvard Medical School. Asaf is, in addition to his peripatetic international work, is a senior advisor to the Centers for Medicare and Medicaid Innovation, who are now implementing the Comprehensive Primary Care Initiative. We asked Asaf to talk a little bit about financing of primary care and the impact that that has in the ability or the inability of healthcare providers and systems to provide care along the lines that you've seen early on. And we've actually kind of, because of the importance of primary care, highlighted all of service delivery because it's all about the money, I think. And we've asked Asaf to kind of give an overview of the impact of primary care financing models on primary care in the United States. Asaf?
Great. So thanks for having me. You know, what I want to talk about, and I'm going to start off, we're going to talk about some main sort of typologies of financing mechanisms for advanced primary care in the US. We're going to talk about some use cases of those examples, and then I'm going to give you some opinionated summary thoughts. What I'm not going to do is the following. Make excuses for, quite frankly, a crazy payment system in the US and many high and low income countries. I'm going to take the angle, so to Dan, Hong, Jack, and others, I'm going to take the angle not as an economist, which I am not, as you well know, but it's a hybrid angle of a practicing provider in an integrated system plus a person who's been working on the policy side of financing advanced models. So we're not going to have a deeply theoretical conversation, I hope. I'd like to have a conversation of what are the different typologies of financing, what are the trade-offs. There's no perfect model, and we should just talk about the trade-offs as opposed to sort of pretending that there's one sort of Shangri-La out there. The other thing is that this talk made a lot more sense a day ago. I just want to be very honest about that. And I'm going to speak, you know, I have a role at CMS at the Innovation Center with this model. I'm not speaking for them. I'm not speaking on behalf of any public agency. I'm going to give you my thoughts, but I think it goes without saying that there are no certainties in what we had as a pathway for discrete, I would say, you know, somewhat impactful progress that we've made over the last 5 years. And quite frankly, I think we can all acknowledge that it's all up in the air. There is, now, we can have a really depressing conversation of how bad it could be, and I don't disagree that it could be really bad. But we should also, as Bob Phillips and I had a discussion just now, and this is just emerging, and I want to throw this out there, Andy and I talked about it too. For the purposes of the US, we should also be very clear that in the case where we have a candidate and a transition team that, and again, I'm going to try to be as apolitical as possible, but that don't really have a set of ideological norms around healthcare and have been very disengaged with healthcare and the ACA and all that's been going on that you've been seeing across, you know, this day. There is an opportunity if we're willing to be open-minded and willing to engage the transition environment, and if that incoming administration is willing to engage in a very sort of pragmatic conversation for saying, hey, you may hate the Affordable Care Act, and you may hate a bunch of the innovations that people in this room are doing, but perhaps before you dismantle it all, we can come to common purposes and say, we can help you save money, and you don't like to spend money on social welfare and healthcare, and maybe we could do well by doing good and you know, sort of call it a day on an ideological basis. Now, I have no idea, and I think we should all be really clear that prognosis is sort of out right now in terms of predicting the future. I have no idea which way that will go, but I'd like to suggest that there are some alternative hypotheses possible. So, given that, I then have one more thought and three questions about primary healthcare financing. So the first observation from my experience, both as a recipient of crazy primary healthcare financing mechanisms, as you well are as well as a person who's been trying to tinker and redesign and study those impacts, the observation that's not going to surprise you is that most delivery systems are designed to support financing models as opposed to what they should be done, which is financing models to support delivery systems and their end health goals, which should be health, not health care, as we've heard throughout the day. Now, that is unfortunate that requires saying, but it is really a fundamental truth of the design of payment models across advanced economies, and I'd argue also in low and middle income countries. So the three questions to ask when you're looking at least from the provider side on the design of the payment model is, what are you actually buying? What is the unit of transaction or the unit of service that you are actually buying with the financing model? How do you know that you're actually buying it? And how do you sort of monetize or quantify it? So the example being, all the way in fee-for-service, are you buying a widget service, either a time aliquot of a provider's time, or a drug, or a lab test, or a procedure, or et cetera? Or moving along the spectrum, are you buying, or do you think that you're buying a unit of technical quality, like, as Bob talked about, let's say A1C control, or prescription of a certain medication, like for lipids, et cetera, in a pay-for-performance contract? Or are you buying a time unit in which you bundle the cost of an episode of service that may be an episode of service for all the diabetes care, or maybe the episode of the entire service for all of a primary care package of services, or it could actually be the entire cost of the patient's care, no matter what, over, let's say, a unit year, or it could be the unit just as simply a global budget. I will give this health agency or this impaneled group of patients X amount of money, and you can spend more or less, but you have that amount of money. The other part of this that's really important is, unlike some of our discussions in low and middle income countries, I'm going to assume that we're in mixed systems of financing, meaning public-private, because that's, quite frankly, obviously our system here. So this isn't solely a discussion of a public financing system or a solely private system that's, employer insurance. It's intended to sort of be both. And in terms of how do you know what you're buying, I think we always have to ask with each of these increments, and I'm going to give you a very simplified scale that we kind of think about. Do you know that you're actually buying that unit of service or that unit of time or that unit of quality? And how sure are you that you're actually buying the thing that you believe you're buying it? So here's the admittedly overly simplified scale of, on one side, and again, this comes with no value judgment. It's all a bunch of trade-offs. And I'm not going to say it's all about global cap or total budget. That's where we should be moving to, or it's all about fee-for-service. They're just a bunch of trade-offs, as you well know. But on the most sort of quantified unit of service or time, you obviously see fee-for-service, where you have a limited range of options in terms of basically 15 or 20-minute visits with some lab tests and some ancillary procedures. Moving along to, again, this is not sharp increments, but it's fee-for-service plus pay-for-performance. So you set a number of technical quality targets. And it's really important, if I may just say, there is an enormous division that's unfortunate between technical quality and experiential quality. And Don Abedian, in his formulations of quality, never meant for those quality boundaries to be so separate. So technical quality, did you do a service with a certain technical proficiency? Experiential quality, did that service provide the experience that the patient needed in order to receive it, use it, and excel with it, and done in a respectful, well-communicated manner? So you could measure mostly technical quality and pay off of that. You go to the next step, which often bundles these together into a per member per month, in which you allocate, on top of fee-for-service mechanism, some unit payment for patients in a panel. You could then add shared savings to a spending target on top of that. Again, they're sort of aggregates of each other. And then you can start saying, forget about all this quantified units. Move to an episode-based payment, where the episode is often, a time period with a disease grouping, or a time period with a patient panel grouping. So, again, bundle off of diabetes care, bundle off of primary care. You could move to a full bundle, which is essentially capitation. We are going to give you, in, let's say, a risk-adjusted basis, X amount of money per month for a group of patients, and then there you go. Have fun. Now, you can obviously imagine that there are trade-offs, as our economists in the room will tell you, that on the fee-for-service side, you incentivize productivity, but you have a problem with wondering if you're actually trying to produce the end goal service. And on this side, you run the risk of basically skimping care and still not necessarily producing high quality or effective coverage of the services that you want. So that's kind of the typology that I'd like to sort of give you 4 quick use cases around. The first is, again, these are just to say there's some positives, there's some negatives. You decide, you discuss. You have, let's say, the UK pay-for-performance program, which Bob talked about, but which is kind of the epitome of a lot of pay-for-performance programs that most of you have been involved in. And it goes somewhat like the payer sets a certain target level for a certain decided number of technical quality measures. And what happens in really good studies in New England Journal? Well, providers do them. You can provide it on a bonus level or on a withhold level, meaning that they withhold a part of your salary unless you achieve certain targets. And what you see is that those processes improved if you pay for them, but actually not all of them improve equally. And I think most important are the 2 results here. Initial acceleration is not sustained over time, at least, again, in advanced economies. This is a more nuanced conversation, I would argue, for results-based financing in low and middle-income countries. But in advanced economies that are trying to do this for primary health care, initial acceleration is almost never sustained, and there are unintended consequences, especially around experiential quality, and especially around aspects that are just not covered by that technical quality bundle. I think honestly, if you look at all the big reviews of pay-for-performance in high-income primary health care, they end up concluding some version of this. So the next thing that you could do, and this is the sort of, I would say, over the last 7 years, is you could take a team-based primary care model, like those described, to different levels of efficacy in the medical home model, and you say, let's put together some of the pay-for-performance mechanisms, some of the monthly sort of payment mechanisms to actually build a team. So maybe we'll give you $3 or $5 risk-adjusted to build that team, so it's not all keyed off of visit-based care, and see what you can do there. And in some of the newer experiments, actually tie that to a total budget target in which you can share off of the savings if savings are incurred. And often in the biggest pilots, those savings are set to like a minimum savings ratio of 2%. So you save more than 2% off the total target, you get to share 50-50 off of any additional percentage. And that's a very common model. And we've actually done a big study on this. Of the 21 million patients that are in the US in these kinds of model, the range of per member per month was wide. So some get a quarter per person per month. That's almost laughable. And some were up to $60 per person per month for the highest risk tier of complex patients. And they utilized a wide variety of payment mechanisms. So a few utilized enhanced fee-for-service. They just paid fee-for-service visit levels at a higher rate, but that was a small number. A bunch used fee-for-service and this per member per month. Even more did all of the above plus some pay-for-performance targets. And half of those overall use shared savings. And that's been the new general innovation in, again, private insurance and federal insurance pilots or state Medicaid pilots is to start tying in this sort of shared savings target on top of this hybridized model. But keep in mind, the dominant payment structure for these practices and for providers is still fee-for-service. So we can have a nice discussion about, isn't it theoretically great that we have all these incentives, but when you derive, let's say, 80% of your revenue still from seeing E&M visits for 15 minutes, guess what you're going to do, right? And very few have moved to full capitation. So we've teamed up with some really, with this guy Sanjay Basu at Stanford and some other colleagues in Boston to run a model that's basically a micro-simulation model of what are the economic incentives to do team-based care. So we priced out team-based care, and we put it in a model, and we priced out all the services, not all, but almost all of the services. So nurse-led risk-stratified care management, group visits, asynchronous visits, other sort of key elements of the medical home model. And we then got state-level data costing out in private and public payer settings the cost of providing the care and providing the staff for the care. and then ran through thousands and thousands of simulations. And there are enough variables in the model just to let you know that Sanjay has an affiliation with the Stanford climate change computer model and runs the model through their climate change supercomputers. That's just how many variables are involved here. It takes about 20 hours to run a simulation. And what's the upshot here that I want you to take away? The upshot is twofold. Number one, current primary care in the US, in our model, in every state that we looked at, is basically over 99.5% efficient from a sort of economic efficiency perspective to produce the number of visits and be staffed just enough to produce those number of visits to, per their sort of fee-for-service and reimbursement. When you add in a little PMPM or a little PMPM plus P for P, yes, they'll do more, but the bottom line here is they're maximizing to the basically net amount that they can, current staffing ratios and current productivity targets and current non-visit-based activities to do exactly but no more than that. And there is absolutely no incentive for them to actually accomplish a lot of the things, a lot of the most interesting and ultimately most beneficial priced out strategies that you've heard about today. So the model basically gives you just about what fee-for-service and a little margin gives you and no more. And therefore, you'd really need more radical payment reforms in a different economic structure to basically create this. And now the second paper, this was in Annals of Family Medicine this year. There's a second paper that's going to come out and said, if you moved, as we'll see in this next model, to a capitated or a hybrid capitation structure, then there is a break point with capitation after which you start to incentivize the activities around team-based care, and it doesn't cost practices money so that they can sort of do well by doing good. And that's the last two models. So again, just to present the next thing on the table. So IORA is a company that's VC funded, and they basically subcapitate primary care services, team-based structure for high-cost, high-risk patients. And they basically say, we'll give you a primary care bundle or a year-long episode payment. The employer or the union will provide wraparound insurance for specialists in inpatient care, and then they'll share in the savings. And they've been doing this model for about 4 years. They have some interesting results. They're scaling across a number of states. I'm not here to say good or bad. I'm just trying to, we're providing a cartography of primary care financing options. We're going spelunking through maps here of how you can do this stuff. And then finally, and again, full disclosure, I work on this model, so I'm totally biased, but it's just another step. We have this Comprehensive Primary Care Plus, which is run out of the CMS Innovation Center. 2 tracks. The first track is really that kind of traditional P for P and PMPM and shared savings. And the second track is where I think things get more interesting, which is that there is a higher PMPM level. There is a performance-based incentive payment, but there's also an opportunity to start splitting apart your fee-for-service payments into either a 40-60 share, in which 40% is basically a capitated population payment, estimated based on last year's total fee-for-service, and then given a 10% bonus in case things are a little goofy, so that you don't basically go under trying to do a new payment model. Or you could be even riskier, and I present this target because it turned out to be really interesting. A 65% capitation, 35% capitation fee-for-service split. Why do I present that? And this was sort of nothing to do with each other, but our new simulation, and this is kind of new news, but at about 68% capitation, you start to incentivize team-based care away from unit-based transactional fee-for-service. I can't say we were that smart to know to do 65, but that's kind of interesting. Now, again, that's a mathematical model. It could be wrong in real-world settings, but it's at least interesting to think about. So the conclusions, there's no one best model. It's just a question of which things you want to trade off on. You probably want to consider designing the finance system to support the delivery model you want, as opposed to the current mechanism that we basically design our delivery around financing that has basically a historical accident, and we can discuss the ruck and all those other interesting, crazy parts of primary care financing history if you want afterward. Be mindful of the unit of transaction and make sure you ask yourself what unit are you actually buying when you're buying it. Watch for the unintended consequences and always be in that iterative improvement cycle even with something as sort of rigid as financing. So acknowledgements here.